happy to have Hassan here with us.
So good afternoon, and thanks to SOCIP for inviting me up. So the one thing is we saw a lot of different cases today, right? You may have been interested in some of the upper extremity stuff, some of the lower extremity stuff, some of the sportsy ligamentous stuff, but the one thing all those people have in common is all that stuff hurts like hell. And so maybe we can talk a little bit about how to manage patients' pain more responsibly than what we have been doing as a specialty over the last couple decades. So I've got several disclosures, and I'm willing to take on some more. So you guys have probably heard a lot of these stats yesterday. I know Asif gave you guys a talk on the opioid epidemic yesterday and kind of the Pennsylvania response. But just to highlight some things, that as a population in the United States, we're less than 5% of the world population. We use 99% of the hydrocodone and 80% of the opioids. And these stats are a few years old, but they still hold true. We're not making a big dent in these percentages. The opioid epidemic, or so it's coined, is really having to do with the number of deaths that are occurring. They've quadrupled over the last couple decades, and there are more deaths than heroin and cocaine combined, and even more than motor vehicle collisions. One of the new actors now, and that's being given more press in the last year, is fentanyl and fentanyl analogs. And so we may actually be underestimating the death rate of opioids, because most of the ones that we track have been prescriptions, but now with all these fentanyl analogs, some of these are coming in illegally from Mexico, so our death rates may actually still be climbing. We think of the opioid epidemic as being a U.S.-centric phenomenon, but it actually is just as bad, if not worse, in Canada. A few months ago, I was given a talk in Canada and just wanted to compare, and their rates are equally disheartening with their patient population and the public, and their death rates are on par with what's happening in the United States. But what about the rest of the world, right? Typically, the term epidemic is not really for one nation, it's for the whole world. So if you look at the trends in morphine milliequivalents used over time, over the last couple decades, it really has been a global phenomenon in opioid use. However, it's not really perfectly spread out or distributed across all countries. So when you have healthcare systems that are more developed, we're actually overutilizing opioids, but some people have coined the fact that there may actually be two opioid epidemics, and that there's also under availability of opioids for patients who truly need them, terminally ill cancer patients, et cetera, in certain regions of the world. So we actually have kind of two parallel opioid epidemics going on. We may need to figure out a way to redistribute how they're utilized. So deaths are the thing that gets all the headlines, but also, as we all know in healthcare, for every one that you see that a patient passes away, we have exponential number that we see other problems, where they come to the ER for pain medication refills, or they have abuse disorders, or people are just using medicines that are laying around the house and getting in car wrecks and committing crimes, et cetera. So it's a big societal problem beyond just the death rate. There's tons of headlines every week. You can look in every major publication throughout the U.S. In the lay press, and there will be more and more headlines. Here's a couple that may catch your attention as healthcare providers, in that there's now precedent. There have been a few convictions now of physicians whose patients died from opioid overdoses, where the physicians have been convicted of murder. So if you're prescribing these things willy-nilly and your patient happens to die, you could actually be convicted now. Also, on the flip side, this is a PMNR physician in South Bend, Indiana, who was killed in his parking lot last summer for refusing to write an opioid script for one of his patients, and then her husband waited for him in the parking lot and shot him as he walked out the door to go to his car. So, it truly is becoming a life or death issue. There have been several reports across the country of violence in the workplace, in hospitals, and in practices, and I bet a lot more of those have to do with opioids now than in the past. So where do all these misused prescription opioids come from? A lot of them come from relatives or friends, but ultimately, if you trace back all of these, they all come from prescriptions that we write, and then there's a subset of these where patients get them from more than one prescriber and more than one location, and that's so-called doctor shopping. To try to combat doctor shopping, nearly every state now has a prescription drug monitoring program, and 37 of them now currently require you to use it. Missouri doesn't have a state program. They have a program in St. Louis County, but they're the only state without a PDMP. So what is our role as orthopedic surgeons and orthopedic providers in this? So even though we only make up about 2% of all of medicine, we're really out-punching our weight class in that we're the 4th highest prescribers of opioid medications. But if you look at the first couple categories, the PCPs and the internists, I'm not sure how they delineate those two, but a lot of what they're prescribing is for musculoskeletal conditions. So we actually could have a much larger role in helping to deal with this epidemic and helping to deal with pain control beyond just what we write, but also in helping educating other providers on how to best manage musculoskeletal care. So there's tons and tons of literature now about opioids. Every subspecialty journal every month has another 1 or 2 or 3 opioid articles, and there's more and more coming to show that they really do affect our patients' clinical outcomes. So this is one that we did a while back when I used to live in Tennessee and was at Vanderbilt University, and we had our PDMP enforced on us when I first started practice there several years ago. And so we just wanted to look up and see how many of our patients were using them preoperatively and then how many of them were getting them from multiple practices postoperatively. It turned out that about 1 in 10 of our patients was already on them preoperatively, and 1 in 5 of our patients was not only getting them from our center, but was going out and getting prescriptions from other places. And that was pretty striking, especially considering that we lived right near the Kentucky border and people could cross over there and get more prescriptions and we couldn't even track it. So for the average patient who is getting them only from us, they would get on average 2 scripts for 3 or 4 weeks, and you can see the morphine equivalent dosing. But those who are getting them from multiple places got triple the amount of prescriptions for almost 3 months for double the dose. So it really did make a big difference on when they were getting them from just one place versus multiple places. And how much is too much? When you look at morphine equivalent dosing, what does that really mean? So in a lot of what we prescribe, we're right at the threshold for increasing the risk of death and increasing the risk of addiction right in our wheelhouse of what we're routinely prescribing, the amounts we prescribe per day. So this is certainly right in our realm of what we're doing to our patients. So there are several risk factors when considering patients who are going to engage in non-medical use of opioids. And I think that some of these risk factors we have to look beyond just the x-rays, right? So this is a P-line I did a while ago, kind of a sweet-looking construct, and if you just look at the x-ray before you go in the room, you may think, all right, whatever, I'm just going to see this guy. It's his first post-op visit, not much to deal with. But he's attached to a whole lot of other things, right? This guy actually happened to be a maintenance worker at our hospital with a young family who wrecked their only car, and he also had a history of being on opioids for low back pain and a history of depression. So when you put all that together, it helps you come up with a better plan of how to manage this patient's pain and try to get him off of opioids and direct him to other modalities. And other modalities, you hear multimodal all the time, right? But that doesn't mean just other medications. You have to help deal with these other things, helping him with work forms, talking to him about depression, and at least making sure that he's getting care for that, whether it's from a psychologist, psychiatrist, a primary care doc. But taking a couple extra minutes in clinic to deal with these other issues, you can get to the source of what their pain is, because a lot of times if you look at the literature on pain, it coincides more so with anxiety and depression than it does actually with nociception or a stimulus from the peripheral nerves. So a lot of it truly is in the patient's head, and you have to address those other things. So this is, David Ring has done a lot of work on that, of what I just mentioned, looking at the psychological aspects of pain. And really, it's those patients who have more psychological distress and less effective coping strategies who are going to be more likely to be on opioids for long periods of time. We have to balance that, of course, with patient satisfaction, right? We all have these HCAP surveys and other issues, and we all want to get great scores, and so we think that part of that is prescribing more pain medication, but it may not be the case because it actually is counterintuitive, but patients who get less opioids are actually more satisfied with their pain relief. And the biggest thing there is helping them with their self-efficacy, convincing them that they can get through this process. Because nobody plans to wreck their motorcycle, right? People can plan for their total knee or their total shoulder, but they don't plan typically to wreck their motorcycle or wreck their car. Along with societal expectations is that what we do in the U.S. compared to the rest of the world, and this is in the developed world. So this study has been highlighted several times. This was another one from David Ring, showing that for another developed healthcare system in the Netherlands, they use very little opioids for ankle fractures and hip fractures compared to nearly all of our patients. I think of the last time you had a hip fracture or an ankle fracture that you gave 0 opioids to. Probably pretty rare. So this was an article I wrote a couple years ago now, and at the time I was the strictest guy at our practice in Nashville, right? And I was kind of seen as, man, you're the mean guy in the department, you're giving less opioids than everybody. And then I moved to Florida a couple years ago and was told by my practice down there, dude, you're a candy man. You give out more opioids than anybody down here. So it's kind of funny that within your own department and within your own cities, there will be a lot of variation on how much to prescribe and what to prescribe. And that's what's led to, I think, a lot of these problems is that we don't really have good guidelines on what to do. So I wrote a new protocol then when I got to Florida, and then in thinking about it more so, it was like, well, really one size does not fit all, right? Should a distal radius fracture get the same thing as bilateral femurs with a tibial plateau? Probably not. So now there's newer protocols that I've worked on, and that these go into, my assigned topic was what is our national organization's response. So this is a little preview, publish ahead of print sort of thing of the Orthopaedic Trauma Association guidelines that are going to be coming out on clinical management of acute pain, right? This is not chronic pain. This is acute pain after musculoskeletal injury. So we have all these best practices that aren't just how many pills to prescribe, but talking about cognitive strategies, physical strategies, system strategies, other things you can do beyond just what you're writing or e-prescribing. So we came up with protocols for major musculoskeletal procedures, minor musculoskeletal procedures, and then for non-operative treatment of various injuries, trying to minimize the amount of opioids given and the length and duration. The thing is, though, that will supersede any guidelines we put out is several states now have regulations on what you can prescribe, and we'll get into that. So as I mentioned earlier, we're not the only ones prescribing. We're probably a small number of those prescribing for musculoskeletal conditions overall. In the ER and in outpatient clinics, the number of opioids prescribed has doubled, even though the number of visits has not doubled for musculoskeletal pain. Along those lines, with pain clinics, right, no discussion can go on about musculoskeletal pain without discussing pain clinics. So when I first moved to Florida, I found out that there were about 4 pain clinics for every 100,000 people. I didn't really know how to equate that. So the way that equates is that outnumbers McDonald's restaurants. So every McDonald's you see, there's at least that many pain clinics, if not more than that, in the state of Florida. So think of that next time you visit Orlando or Tampa and are driving around and seeing Mickey D's. So some of these are actually legit, and I have a few friends who run pain clinics who actually have prescribed 0 opioids, and there are places where you want your patients to go. The only opioids they'll prescribe are to try to get people off of them, versus there are still pill mills in existence that just keep writing these things like crazy and hardly even see the patients, but will keep giving them more and more medications. So there are several interventions. We'll talk about them at different levels. So at the state level, the prescription drug monitoring programs actually have had a major impact on doctor shopping and on non-medical use. And this is in both the states that require you to look up every patient and the states that don't require you to look up every patient. Obviously, the effect is nearly double in the states that force you to look up every patient before prescribing an opioid medication. Insurance companies have gotten in on the act and will stop filling scripts, and there have been a couple of pilot programs in different states that have significantly decreased the amount of opioids that are given and decreased doctor shopping as well. The CDC came out with their guidelines a couple years ago, and these are just kind of overarching broad guidelines, which, at least give us a starting point. They don't necessarily tell you what to do. They just tell you to, which is kind of common sense, to use less of them and not use long-acting ones, which at least at the institutions I practiced, a lot of the orthopedic surgeons were not using long-acting ones, but a lot of our patients would be admitted to the general trauma surgery service who still are using long-acting ones, but now, given the increased education going on, we're cutting back on that. The Canadians also came out with their guidelines in 2017. CMS has agreed to remove pain management from the HCAP survey and from their scoring, so that should help at least with our fear of patient satisfaction being affected by writing less opioids. And then several states, this is just a list of all the state laws from last year that were going on, and you can see, what is it, about 35 or so state laws that were being considered last year in relation to opioids. A few examples this is from Massachusetts, where they have prescribing limits of 7 days, and then also the amount that you can prescribe. New Jersey also has had one signed, I guess, a couple years ago now that was a little more strict even than the Massachusetts. And in Florida, ours goes into effect on July 1st, and it's extremely strict. It's a 3-day limit for opioid scripts. The exception to go beyond that is you can go up to 7 days for post-surgical acute pain in patients who have an ISS, an injury severity score, greater than 9. So an ankle fracture, tibia fracture, et cetera, you can go beyond. But I think for a lot of acute joints and things, they're going to be limited to 3-day supplies of opioids, and this is going to be a major game changer. The other thing that's different in Florida than a lot of states is for every opioid script that we give for any trauma patient, whether it's 3 days, 7 days, whatever it is, we also have to give them a Narcan prescription. So we already have started this at Tampa General before the July 1st deadline just to get in the habit of doing it. And our pharmacy has run out of Narcan within the first week of us enacting this. So it's going to be a major change in practice throughout the state of Florida. As an aside, I don't know what company or what stock you should look into, but Narcan stock or that company should be a good one to purchase. So a couple other major initiatives around the country of what our national organization responses are. The AMA has done a lot with this. The Surgeon General has the Turn the Tide program that is making a difference as well. The Academy does not have a clinical practice guideline, but has made an information statement a couple years ago on this. Has a toolkit which gives you little scripts and things that can help in the discussion with patients. Has little screening questionnaires if you're worried about risk factors for being on opioids. And then did a public service announcement that really has gone a long way in helping further this discussion with legislators. And this is from, so I wasn't here yesterday, I was in D.C. for the National Orthopaedic Leadership Conference, which is where we meet with a bunch of congressmen and women to discuss different topics. And the big topic this year was the opioid epidemic. So this is the from Twitter, from the Pennsylvania Society delegation. And there's 2 bills currently being considered by the House. One of them is the Every Prescription Conveyed Securely Act. That's basically going to require that all opioid scripts be electronic with 2-level authentication. So then it takes away the issue of stolen prescription pads, et cetera. It's just everything's going to be electronic and can be tracked very easily. The second one is the Monitor Act, which right now every state PDMP is different. And none of them talk to each other, and none of them talk to your EMR, and it's a huge pain in the butt to look up all your patients. Well, this will actually hopefully try to change all that in forcing there to be a common standard for all of the state PDMPs, so then they can communicate with each other and communicate with your EMR so you don't have to log into multiple systems to look up your patients. It just kind of pops up. Again, this is what I mentioned that's to be coming soon from the Orthopaedic Trauma Association, which will be our guidelines for pain management for acute musculoskeletal injury. It's a comprehensive literature review with a ton of good recs. At the institutional level, Joe Hsu at Carolinas Medical Center is a big leader in this area, and they've actually created within their EPIC system, because Carolinas Medical Center is unique in that their healthcare system dominates the whole region. They've got tons of hospitals and all the clinics and all the pharmacies. So they've got these pop-up warnings every time you write a prescription that looks at the patient's risk factors and tells you, hey, are you sure you want to prescribe this? And hey, maybe you ought to go down to this. But they still don't have their state PDMP integrated into that. A few states are doing that. This is from a report from Congress from a few months ago that Ohio, Wisconsin, and Illinois are going to be the first 3 states that are going to have their state PDMP connected to their electronic health record. So when you log into your chart in clinic or in the hospital to write a script, it'll automatically pull up your patient's report. So this is from the Pennsylvania Orthopaedic Society. I think this was from 2 years ago, the state guidelines from the Orthopaedic Society here on helping to combat the problem with opioids. And so in conclusion, sorry, I know there's a lot of information. I'm trying to get us caught up a little. I think it's clear, everybody's heard about it. We have a major problem that is detrimental to our patients and on society as a whole. And not only are our patients at risk, I think you saw with those headlines of convictions of physicians and murder of physicians that we're at risk as well. And that at minimum we should recognize risk factors in patients at risk. We should probably be doing a better job, which is hard in trauma, but it can be done, of setting expectations and prescribing responsibly, using multimodal, not only more medications, but different modalities to treat pain. And we should probably be the leaders in musculoskeletal pain management for other specialties as well. And thank you, and I'm happy to take any questions.